Yeah.
Yes, sir, you're audible.
Okay. So warm greetings and good evening to all of you. On behalf of JIPS editorial team, we welcome you all to yet another, I think, 7th episode of JIAPS Abhigyan, this general club. This is has become like a collaborative learning, and it has been quite successful the last 6 episodes. So in this episode also we have quite very good handpicked 3 manuscripts to be taken up by our esteemed moderators for today. So before we begin, actually, I would like to invite our JIP's editor-in-chief, Dr. Rasik Shah, sir, for his introductory remarks. Rasik Shah, sir.
Yeah. Thank you,
Yes,
Manoj. First of all, I thank all editorial team for helping us in reviewing and editing and proofreading, etc. Without without the help of all IAPS members, this is a tough task. It's not an easy job to take care of the journal, and particularly when the work is increasing day by day. Last year we got 310 manuscripts for review, and this year probably it will be around 350 to 360, looking at the number of articles which we are getting. At the rate of 60 to 70% acceptance, we should be publishing around maybe 200 to 230 to 40 articles in 2025, which is a big number. From April, we will be along with the Publon. So all the reviewers who are reviewing the articles, they will get recognition also. It gets recorded, whatever you are reviewing, how you are reviewing. So that number will keep on increasing. So that is the benefit for the reviewers which you are going to get. I'm sure many more reviewers would be interested, and we may not be able to get in touch with everybody. But if anyone, you or your seniors or juniors who are at least 5 years in pediatric surgery, if you have spare time and you have interest in reading the articles and reviewing, then please contact any one of us, me, Manoj, Vijay, or anyone from the editorial team. We can add you in the reviewers list. We have more than 300 reviewers. Of that, 100 people are active. So we need reviewers, and please do contact us. Apart from that, again, as you know that we have this Abhigyan going on, and this is the 7th episode. And from now on, or since this year, what we have started, uh, we will be selecting one paper out of whatever, or rather 3 papers are selected for presentation. From that, one paper will be uh, said winner. So we'll have 6 manuscripts which will come into the final round. Of that, one will be awarded during our annual conference of IAPS. So judges for today's session are Rakesh Joshi and Amar Shah, and along with them, they are the moderators and judges. Along with them, me, as well as if Vikesh and Sumitra Bishwas is there, 4 or 5 of us, whoever is around, will be finalizing the who is the best paper for the today, and we will let everyone know about it. With these few words, I will request Manoj Joshi to continue with the proceedings.
thank you. Thank you, sir, for that very valuable information. For today, we have 3 very nice manuscripts lined up for presentation. This is from March-April 2025 edition. And the moderator for today's session are two very esteemed pediatric surgeons, both from Ahmedabad. Both needs no introduction formally. Dr. Rakesh Joshi, sir, and Dr. Amar Shah. So I would like to hand over the session to both of them to please continue and invite the presenters, sir. Thank you very much. Rakesh, sir.
Rakesh, do you want to start?
You may start if he's not.
Okay, so good evening, everybody, and welcome to yet another edition of JIAPS Abhigyan. It's a really novel and a very successful program which has been going on since last year. And I'm happy that I have been invited for the 7th edition. So now we'll start with the first paper, factors associated with spontaneous passage of ingested foreign bodies in children, a prospective observational study, and Dr. Veerbhadra would be presenting it. So Veerbhadra, you may please start the presentation.
Good evening, everyone. I'm Dr. Veerbhadra, Assistant Professor from Bangalore Medical College. As Sir has already spoken the title of our article. So to introduce, as we all know that 80 to 90% of the ingested foreign bodies pass through GIT without causing any problems, whereas 10 to 20% require endoscopy for retrieval and around 1% require surgery for complications of ingestion, such as obstruction or perforation. Certain unusual complications also have been documented in the literature. Some of them, but they're not just restricted to them, are Meckel's perforation, appendicitis, pyogenic liver abscess. Despite being one of the commonest conditions in pediatric age group, there is no universal consensus on the indication and timing of endoscopy for pediatric foreign body ingestion. With advancements in pediatric endoscopy, endoscopic retrieval has been increasingly considered rather than waiting for it to pass spontaneously. Hence, we conducted a study with an objective to identify the factors which influence the passage of foreign bodies spontaneously with the aim to avoid unnecessary endoscopic interventions. It was a prospective observational study conducted between July 2022 to March 2024. Children under 18 years of age with history of foreign body ingestion were included. Children with esophageal foreign body, radiolucent foreign body, multiple magnets, magnet impacted foreign body, history of known GI pathology or surgery were excluded. Children who presented with complications of foreign body ingestion such as intestinal obstruction and peritonitis were also excluded. The study was registered with CTRI after ethical approval. The sample size calculated was 139. At presentation, the foreign bodies were divided into gastric and intestinal foreign bodies. If the child in gastric foreign body, if the child was less than 5 years and had ingested a button battery more than 2 centimeters in size, a repeat X-ray was advised at 48 hours. And if the child was more than 5 years and the button battery size was less than 2 centimeters, a repeat X-ray was advised at 7 days. All other foreign bodies were also advised repeat X-ray at 7 days. An endoscopic removal was done if the foreign body did not move during the stipulated period, or if the child developed symptoms within the stipulated period of time. In intestinal foreign bodies, all asymptomatic children were followed up serially with X-rays at 7 days, 14 days, 28 days, and then monthly, whereas symptomatic children were intervened. During the study period, we got around 212 patients with foreign body ingestion. 56 were excluded, and 156 were allowed to pass spontaneously. Amongst them, 6 required intervention, and 11 did not know the time of passage, and 139 were analyzed. The mean age of our study population was 6.9 years. Boys constituted 53% of study population. Blunt objects were the predominant in our study population, around 60%. The median time at presentation was 12 hours, with a range from 1 hour to 11 days. Most of the children were asymptomatic. Around 13 children presented with pain abdomen, and predominantly 10 of them, in the sense, 10 out of 13 were sharp objects, so which was quite significant. History of vomiting was present in 4% of the children. 14% of the children had history of constipation, but on X-ray, around 73% children had loaded colon. These are the various foreign bodies which we encountered, which range from coin to button battery, jewels, hair clip, paper pin, key, open safety pin, closed safety pin, metal nail, sharpener blades, etc. In our study, the spontaneous passage was 96%, and there was no difference between the blunt and sharp foreign body in terms of rate of spontaneous passage. 6 children required intervention. All were impacted foreign bodies in stomach more than 7 days of ingestion, which included 3 coins, a button battery, and 2 sharps, which included 1 nail and 1 hair clip. Sharp foreign bodies were found to have a quicker spontaneous passage compared to blunt foreign bodies. The diameter of the blunt foreign body, if they were smaller, they had a quicker passage, whereas the larger blunt foreign bodies had a delayed passage. Which diameter of the sharp foreign body also had a similar effect on the spontaneous passage, whereas length of the sharp foreign body had no effect on the spontaneous passage time. Children with constipation as well as children with loaded colon were found to have delayed passage time. An Norvus analysis showed that if a child comes with a blunt foreign body ingestion with a diameter of more than 1.75 centimeter, the spontaneous passage time was at least 72 hours, whereas no certain cutoff were found for the diameter or the length of sharp foreign bodies. There was no effect of age, sex, or weight on the spontaneous passage. There were no other complications observed in our study. Our follow-up ranged from 7 months to 28 months. We found that sharp foreign bodies had a quicker spontaneous passage in our study, probably because they had a smaller cross-sectional area, as well as it is also possible that they must be irritating the GI mucosa, which increases the bowel motility, making them to pass out quicker. The irritation may also be a reason for them to present with more abdominal pain compared to blunt objects. It has also been documented in couple of studies in the literature. Children with constipation and loaded colon also had prolonged passage times, possibly because they already have a delayed bowel motility. Our study, compared to many studies in the literature, had a lower intervention rate because the other studies which were mentioned in the literature, they intervened for all the sharp foreign bodies and most of the button batteries instead of waiting. So we demonstrated that a conservative approach, especially for sharp objects and button batteries, is safe and effective. To conclude, most ingested foreign bodies pass spontaneously without complications. In our study, 96% passed without any complications. Sharp objects transit faster than the blunt objects. The transit time was influenced by object size, constipation, and colon loading. Our protocol of waiting for 48 hours in case of children less than 5 years with button batteries more than 2 centimeter and 7 days for all other foreign bodies in the stomach turned out to be safe. These are my references. Thank you.
Okay, congratulations, Veerbhadra, on the nice presentation and the excellent paper. I just have a few questions. How did you evaluate the presence of the foreign body in the stomach by a plain X-ray?
Sir, certain few faint features only we can say about. One is if they present early and the shadow of the foreign body in the midline or in the left upper quadrant is possibly stomach. If it is more down and in other areas, it's possibly small intestine. And it's also possible that in certain X-rays, we can actually make out that in an erect X-ray, if we have taken a stomach bubble can be seen, and sometimes in an outline of the stomach also could be seen in some patients. So these were the features we took it as gastric foreign body.
Did you carry out any maneuvers prior to taking an X-ray just to make sure that the foreign body is lying in the stomach?
No, sir, we didn't make out any.
I mean, one of the important things that can be done is to give the child any aerated drink just before taking an X-ray. So that helps to dilate the stomach with gas. And sometimes when it is difficult to identify where exactly the foreign body is lying, because you said that you have a cutoff time of 7 days before you go in for an endoscopy.
Correct.
So sometimes that is helpful, because if you give the child any aerated drink, the stomach dilates. And I mean, the outline of the stomach is very nicely seen. And sometimes even with maybe an AP view or even a lateral view, you can easily identify whether the foreign body is lying in the stomach or not. Do you guys do your own endoscopies, or do the gastro people help you out with it?
No, sir, we do our endoscopy. Actually, last year we have published an article also.
So extending the question of Amar, like Veer brother,
Yes, sir.
ever you experience that you are waiting for 48 hours or then 7 days as per your criteria, and on endoscopy you are not finding that foreign body, it is already moved or it is not in the stomach. Any such experience or any such?
Sir, not in these seven, patients who required intervention because they were in the stomach when we intervened. All others actually had moved down. So, but only one I remember is like one child came with bronchial foreign body, which we actually posted for bronchoscopy. So next day when we went with the bronchoscopy, we could not identify the foreign body at all. So then we did a CM and it was found that it is already into the intestines. So child has actually coughed up and it has gone into the intestines, not even in the stomach. That was something unusual we found.
Okay, there are a few questions on the chat. Any role of honey for button battery? Have you
We have not tried, sir, and it is nowhere actually documented in the sense there's no guidelines to use it. So what we followed was mostly an ESPEGAN and ESPEGAN guidelines.
I mean, my personal experience is that the parents have a tendency to give bananas whenever the child has ingested a foreign body, and sometimes it becomes counterproductive because it does not help the easy passage of the foreign body through the stomach. Have you had any similar experience?
No, sir. We usually, we don't advise them, and most of them will not have an issue if there is a gastric foreign body. Only in case of esophageal foreign body, they come with symptoms. So in those cases, we don't advise them to give a banana or something.
That's not, that in fact should not be advised, but invariably the parents end up giving bananas to the child before they bring the child to us.
Or some laxatives, many times.
Yeah.
So in the stomach, we did not intervene for at least 48 to 7 days. So we did not encounter that kind of a problem in our patients as such.
Okay, there's a question from Dr. Robert on the chat box that he has had almost 6 cases where he has seen the button battery causing perforation. I'm not sure if he's mentioned whether the button battery has caused the perforation in the stomach or in the esophagus. But have you had any experience of the button battery causing any problems once it reaches the stomach?
No, sir. Once it has reached the stomach, we have not encountered any problem. It's actually one of our patient is button battery, which presented on to us on 7th day. In the sense, almost 8th day. So that day we intervened, and there were no issues with that as such.
One more
Rakesh, any
thing.
questions?
Yeah, one more thing in your paper, you have mentioned the scoring of loaded colon, that is 0 to 5. So
Correct.
based on only X-ray or any other thing, you are looking for, what do you mean by 0 and what do you mean by 5?
Sir, actually, this is like what we used as a lead score. There are other scores are there. So this we found it simpler for us to use. In that, the lead score actually it divides the X-ray into 3 different quadrants. One includes rectosigmoid, other one is descending colon and the up to mid transverse. The third quadrant is like from the proximal half of the transverse colon plus ascending colon. So amongst this, 0 score will be for each quadrant, they will be scoring differently. If the score was given 0, if there was no fecal matter seen on the X-ray, and it was scored 1 if there was any scanty feces seen on this one quadrant. 2 if it is mild, 3 for moderate, 4 for severe fecal loading, and 5 for fecal loading severely with bowel dilatation. This was the lead score, sir.
So it's all subjective,
Yeah.
what you think
Yes.
scanty or what you think mild. It is difficult. And at the
True,
same
sir.
time, you have mentioned in your paper
Yes,
that
sir.
the only 14% of your patient presented with history of constipation, but 73% shows loaded colon on X-rays.
Yes, sir. Actually, it's itself is a big big topic to debate because many scorings are there which based on X-ray. Though history of constipation is like very strict, stringent, where you have to have 1 month history of persistent symptoms, which is like at least there should be soiling after attaining the like bowel continence. There should be a loading colon and should be palpable mass per rectum or per abdomen, and there should be a history of like reduced bowel motility. So all these things should be there. So that is also a little bit stringent. So many times in our OPD also they come with some constipation history, though they've been passing hard stools, though, but they will not fit into the constipation. So that is the other thing, sir.
One last question from my side. You have mentioned that if foreign body doesn't pass for 3 months, either you explore or you go for a laparoscopy. I mean, even though they are asymptomatic,
Actually,
they
we
must
had
be
kept
asymptomatic, right?
correct. We had actually kept a cutoff, but none of our patients actually come with that. So the longest period of time we could wait, it was around 29 days. One child passed on 29 days. The earliest was 6.5 hours. That was the passage time actually. So we did not encounter any of this. So for arbitrarily, we had kept 3 months because we can't wait more than that. So if
No,
it
no.
is more than 3 months, we
Yeah,
thought at
that's what
least
I'm
we'll
asking.
exclude.
If his patient is asymptomatic, 3 months has gone already, what you will go for exploration or laparoscopy, or you will still wait? It is absolutely asymptomatic.
I mean, I would personally wait, sir, but only thing is we had cut a cutoff, at least to rule out and take it off from the study. So that was an idea actually to when we had made a methodology.
So
Okay.
one more question from Dr. Madhu, that the dangerous foreign body is jelly ball. Have you ever encountered that?
Which one, sir? Denture, sir?
Jelly ball, jelly ball.
No, sir, we didn't encounter.
Okay, I think we'll end the discussion on this paper now, and we'll move to the next one. Rakesh, do you want to take it?
Yeah.
Thank you,
Who
sir.
is next? Dr. Sundarya?
Manoj, which one should we take, the ultrasound or the hernia?
Dr. Shiva or Sundarya? Who is there ready?
Sir, I'm ready. Dr. Veer
Okay.
has to unshare his screen, please.
Okay. So Dr. Sundarya is going to present ultrasound guided saline hydrostatic reduction in a pediatric intussusception experience from a tertiary care center in India. Please go ahead.
Thank you, sir. I'm Soundarya. I'm currently working as an assistant professor in IGSH Bangalore. And at the outset, I'd like to thank JIPS for giving us this opportunity to present our work on ultrasound-guided saline hydrostatic reduction in pediatric intussusception. This is our experience from a tertiary care center, which is from KEM Hospital, Mumbai. And it was done when I was working there under the guidance of my teachers there. Our aim was to assess the efficacy of saline hydrostatic reduction in intussusception. Our primary objective was to check for the success rates of saline hydrostatic reduction. I'm so sorry, I think I just lost my screen.
We can see your screen.
I'm not able to see it. Yeah, sorry, I can see it now. Our primary objective was to look for the success rate of the saline hydrostatic reduction, and the secondary objectives were to look for any association between the success of saline hydrostatic reduction with the age of the patient, duration of symptoms, or site of intussusception, and also to look for recurrence in a 6-month follow-up and its management. This was a retrospective study in a single tertiary care center over a duration of 3 years, and our sample size was 103. I'd like to first describe how we do the procedure. So whenever we have to take up a patient for saline hydrostatic reduction, we first keep our OT on standby, we arrange blood, we inform the anesthetist so that in case of any complication during the procedure, the patient can be wheeled into OT without any delay. The procedure itself is done in the radiology room. The procedure is done by a pediatric surgeon with the assistance of a radiologist who follows serologically the movement of saline through the bowel. We allow a parent to stay with the patient during the procedure, and we have found that this greatly allays the anxiety of the patient. A 16 French Foley's catheter is inserted per rectally, and the bulb is inflated up to 20 cc, and this is hitched. We also manually hold the thighs of the baby together, and this provides a tight anal seal and prevents leakage of saline from per rectal region. A warm normal saline bottle is hung at a height of 90 centimeter from the bed of the patient, and the IV set is connected to the Foley's catheter, and free flow of saline is ensured. So the sonologist follows for the free flow of saline through the bowel and looks for the reduction of the intussusception. We also monitor the diameter of the transverse colon. The maximum acceptable diameter is 4.5 centimeter, beyond which there can be a higher risk of perforation. So the procedure is stopped when 1, there's a successful reduction, or 2, if the transverse colon diameter has gone above for 4.5 centimeter, or if there is free fluid in the abdomen which suggests perforation, in which case the patient is taken up for surgery. The saline hydrostatic reduction is deemed successful when there is USG findings of disappearance of the target sign, detection of IC valve, and visualization of fluid reflux into distal ileum and fluid filling into small bowel loops. Sometimes during the first attempt, the intussusception is only reduced partially, in which case the patient may be subjected to a delayed repeat enema, which is defined as a repeat attempt at saline hydrostatic reduction with a time interval of 6 hours in between the trials. But this requires an extremely careful selection of patients by proper clinical assessment to make sure that they're hemodynamically stable and their abdomen is soft with no distension and no signs of peritonitis. Failed saline hydrostatic reduction is defined as persistent intussusception after 3 attempts at DRE or an abandoned attempt at saline hydrostatic reduction due to signs of perforation or peritonitis during the procedure. This is our clinical decision-making flowchart. When a child has an ultrasound proven intussusception, we first clinically assess the child, make sure the child is hemodynamically stable, abdomen is soft, non-distended, no signs of peritonitis. Then the patient is subjected to ultrasound-guided saline hydrostatic reduction. If the reduction is successful, we do a check USG after 6 hours and we start orals and discharge. If the reduction is failed at the first attempt, then we clinically reassess the child. If the child is hemodynamically unstable or abdomen is showing signs of peritonitis, then the patient is taken up for surgery. Or if the patient continues to be hemodynamically stable with the abdomen non-distended with no signs of peritonitis, then we can give up to 2 more attempts of DRE at 6-hour intervals. In this, if the reduction is successful, we again do a check USG and discharge. In this, if it fails, again, the patient is taken up for surgery. So all the data was collected from the MRD and analyzed. For the sake of statistical analysis, we created further subgroups under the age of presentation, duration of symptoms, and site of intussusception, as shown in this slide. Statistical analysis was done with the SPSS software. In our duration of 3 years, we had 105 patients with intussusception, out of which 2 were excluded because they underwent upfront surgery because they had peritonitis signs. 103 patients underwent saline hydrostatic reduction. Our mean age was 22.32 months, plus or minus 18, and we had a male preponderance. All patients had history of abdominal pain or excessive crying. More than 50% of the patients had red currant jelly stools, and about 35% had palpable lump. These were our results. Among the 103 patients who underwent saline hydrostatic reduction, 93 had a successful reduction. So our success rate was 90.3%. Out of these 93, 86 underwent successful reduction in the first attempt, and 3 underwent successful reduction in the second attempt, and 4 in the third attempt. Among these 93 patients, 11 patients had recurrence in a follow-up period of 6 months. They were all managed with saline hydrostatic reduction. Among the 103 patients, 10 patients had failed reduction and underwent surgery. And out of these 10 patients, 4 had Meckel's diverticulum, 4 had gangrene, and 2 underwent reduction with no lead point found. In our series, we had no complications and no mortality. Over a follow-up period of 6 months, we had an 11.8% recurrence rate. All these recurrences, again, you were able to manage with saline hydrostatic reduction. The timing of recurrence was 46% of them had a recurrence in less than 48 hours. 27% had a recurrence in less than 1 month, and another 27% between 1 to 6 months. We tried to look for any association between the presenting factors and success of saline hydrostatic reduction using the subgroups that we had mentioned. We found that age and success of reduction had no association. Site of intussusception and success of reduction had no statistically significant difference. However, duration of symptoms and success in hydrostatic reduction was statistically significant difference in our study. So patients who presented with duration of symptoms less than 48 hours had a significantly increased chance of successful reduction as compared to those who presented later. I think intussusception management has grown leaps and bounds in the last century. What was first managed only surgically, now non-operative reduction is the standard of care. Barium reduction was first described, followed by pneumatic reduction, followed by ultrasound-guided saline hydrostatic reduction. When we compared our study with other large series of saline hydrostatic reduction, we found comparable success rates. One study showed a 1.2% complication rate with perforation, while the other studies did not have the same. In our study, we found there was a significantly increased success rate if the duration of symptoms was less than 48 hours. However, some other studies have found no such correlation. In our study, we found that age did not correlate with success of reduction. However, some studies have shown lower reduction rates with children above 5 years of age. There was a systematic review done by American Pediatric Surgical Association, where they show that 25 studies describe the use of DRE. They all had the same common clinical criteria to choose the patients who can undergo DRE. This was progressive movement of the intussusceptum on the prior reduction attempt. Patient should be stable during the interval period, and there should be absence of peritonitis. Among these 25 studies, they found a 57.2% success rate with DRE, which shows that more than half the patients have avoided an unnecessary laparotomy. The problem is there are no definite protocols for DRE with respect to both number of the attempts and timing of DRE. Number of attempts described in literature varies from 2 to 5, but there is evidence that the success rate is lesser after 3 attempts. And the timing of DRE varies largely from 3 minutes, 10 minutes, 2 hours, 4 hours, 6 hours, and the longest described is 24 hours. The recommendation given by APSA was to wait an interval between 30 minutes to 4 hours is likely to be safe. We have since expanded our study and also done a multi-center comparison of non-operative techniques of intussusception reduction, where we included 2 other centers, one center which did a pneumatic reduction and the other center which did a barium reduction. We found that there was no statistically significant difference between the 3 types of reduction. The time to reduction was significantly lower in pneumatic reduction as compared to both saline reduction and barium reduction. There was one case of perforation in the pneumatic reduction and no complications to the other 2 types. Again, among these 3 techniques also, we checked for any difference with the age and presentation and duration of symptoms, but there was no statistically significant difference in the success of reduction. So each technique does have its own strengths and weaknesses. And saline hydrostatic reduction, the biggest strength of saline hydrostatic reduction is that there is no radiation exposure. And in case of perforation during the procedure, saline in the peritoneum is less morbid as compared to air or barium. But one important factor for saline hydrostatic reduction is the need for a radiologist, where the other 2 procedures are done under fluoroscopy and can be done by the pediatric surgeon solely. So in conclusion, I'd like to say that saline hydrostatic reduction is safe. It has a high success rate. Since early reduction has higher success rates as seen in our study, training primary care providers for early diagnosis and referral is extremely important. So all hemodynamically stable, uncomplicated cases, irrespective of age, duration, and site of intussusception, can be given a trial of hydrostatic reduction. These are my references. Thank you.
Very nice and excellent presentation, Saundarya.
Thank
I
you,
would
sir.
like to ask how much time it takes for a saline reduction, because you are dripping the saline from 90 centimeter. So actually, how much time it takes?
It does take a little longer, sir. It takes anywhere from 10 to 15 minutes, depending on how easily it is getting reduced or not.
And you have already mentioned that you are just waiting for either it is intussusception is reduced or it is a failed attempt, or there is a huge dilatation of the transverse colon. That you have mentioned is like your cutoff is like 4.5 centimeter of diameter. So at what level you are measuring that diameter? Proximal, middle, or somewhere distal? At what
Usually
level actually?
Right. Usually the easiest to measure for the radiologist is the level of mid-transverse colon. So we ask them to, beginning of the procedure, we ask them to identify the transverse colon when the saline is just entering it. So keeping that as the same place as the baseline, we continue to measure at the same site. Usually mid-transverse colon is used.
So you mean to say all those who are reduced, your transverse colon never go beyond that limit, right?
Yes, sir.
Right.
If it does go beyond 4.5 centimeter, we actually stop the procedure. We deflate, open the Foley's catheter, deflate the abdomen, and then we go ahead for another attempt at delayed repeat enema. But we would not continue with the transverse colon diameter more than 4.5 centimeter.
So one more thing which was interesting was that you mentioned that you go for a sonography 6 hours later than the procedure is done. So already you are in the radiological shoot, you have already confirmed that it is reduced. Then the second sonography before starting oral, you are doing at 6 hours. That means you are going again with all preparation that you may need to undergo for the repeat procedure if it is visible that time. Do you mean to say that?
True. We are in the radiology room. We have done the reduction, and the radiology ultrasound has confirmed that reduction is done. But we choose not to start orals right then. We wait for 6 hours, make sure the IC valve edema, everything comes down. Do one more check USG to be 100% sure that there is no recurrence or there is no some remnant in intussusception. And then we start orals and then we discharge the child.
Don't you think it is little longer? Because you have to wait for 6 hours and you say you give 3 attempts. So if you consider that 6 hours, 3 attempts is 18 hours and your recurrence rate is more in our first 48 hours. So, I mean, this is what we have to understand that you are waiting too long for that, or this is your experience, but after 3 attempts, most of the time you are getting a reduction done?
Are you talking? No, sir. Like you said, 87 of the patients among the 103 underwent reduction in the first attempt itself. If you see over a period of 3 years, only 7 patients required these repeated attempts. So it's very far and few that are patients who are requiring repeated attempts with this waiting period of 6 hours in between.
But the recurrence rate is almost 11.8%. And in all those recurrences, again, you have done the hydrostatic reduction only. So don't you think there is some lead point or something like that for the recurrence?
Right. So this was a recurrence rate, 11.11% was over a period of 6 months. So again, if we see, most of the recurrence had happened, more than about 50% of the recurrence was in the first 48 hours, which I think is the most expected time for recurrence to happen, if it happens. So those people we are not considering as a lead point. It is a known thing that recurrence can happen in the first 48 hours. For the remaining patients at the first attempt of the first episode of recurrence, we will still give another attempt at reduction. Up to 3 recurrences, we are happy to give an attempt of reduction. If a patient does come with a repeated recurrence, then yes, we will start to evaluate for a lead point if it's indicated.
Soundarya, how were you instilling the saline through the Foley's catheter? Was it with a simple IV set, or did you use an irrigation tube that we use for laparoscopy?
No, sir, with a simple IV set only.
So, were you sedating the child or giving ketamine?
We never use any sedation or muscle relaxants or steroids. We had no pharmaceutical usage in our study.
So, with the a simple IV set, which was connected to the 16 French Foley's catheter, did you have any connector in between, or you just
Sir. We usually use a 3-way. We connect one end of the 3-way into the Foley's catheter and put the saline IV set to it and the other end.
And you were able to generate adequate pressure without any sedation to the child?
Yes, sir. We never use sedation because we're in the radiology room where we don't have adequate support. So it's a department protocol not to use sedation there.
Okay. And how many of your recurrences were actually symptomatic, or were they just picked up on the ultrasound scan?
Yes. I think among these almost 50% who presented within 48 hours, I don't have the exact numbers off the top of my head, but a few were definitely picked up during the routine check USG that we did after 6 hours. But the remaining bulk of them were symptomatic, presented back symptomatic, and then were again diagnosed with intussusception.
Dr. Sinha from Jodhpur says that they don't do a routine check ultrasound and they rely only on the clinical findings.
Okay.
So what is your take on that?
Again, I would say institution protocol, sir. If they are comfortable with that, that's okay. But we have been following a routine check USG to reconfirm before we send the patient home.
Okay. And was the edematous IC junction picked up as a recurrence on the ultrasound, or how was the finding on ultrasound about the recurrence?
If there have been times when if a junior is doing the ultrasound, they would give it as a short segment intussusception of 1 centimeter, 1.5 centimeter. We'd always recheck with a senior if possible. So I think we would have ruled out this misdiagnosis by that.
Okay, so there comes in Dr. Sinha's point of whether the children were symptomatic when the ultrasound had actually shown recurrence.
So I think barring a couple of them who were picked up at 6 hours check USG, the rest of them were symptomatic at presentation.
Okay.
I mean, I'm supposed to ask that. You are there in the radiological shoot and it is reduced. Can you start oral? I mean, just go for a ultrasound if patient develops symptoms.
I'm sure you can, sir. Again, it depends on each person's protocol for sure.
One more question that you have mentioned. There are 10 failed cases during your this study, and out of the 10, 4 patients shows gangrenous changes.
Right.
So all those patients were asymptomatic or taken up for the hydrostatic reduction when they presented, whether they presented in time or late or distension, obstruction. I mean, they were having some gangrenous changes when you explored.
Right.
I mean,
so they were not, you're right, sir. So because the fact that we have given an attempt at saline hydrostatic reduction means that clinically they were not showing signs of peritonitis. And these were not grossly gangrenous bowel. The bowel looks healthy from outside. Once you reduce only the bowel that was inside. So I think most of these have had one attempt at reduction. And when they did not reduce and the abdomen showed any signs of peritonitis, they've been taken up for surgery.
Okay, that's fine.
Okay, so there are no other questions on the chat box. We'll move to the third paper now.
Thank you, sir.
Okay, thanks, Soundarya. You can log out Siva Kamish. Can you share your screen?
Yes, sir.
So the third paper is Navigating Pediatric Inguinal Hernia Repair Conundrum. Occult bilaterality of patent processus vaginalis as an indication for laparoscopy.
Is my screen
Okay,
visible?
please start.
Is my screen visible, sir?
Yes, you are.
Yeah. Thank you so much, sirs. Thank you, organizers, for giving me this opportunity. And a quick thank you to all the attendees of this meeting for having chosen to stay back for the last presentation. So, as sir discussed my title, we'd like to discuss our paper, which is the Navigating of the Pediatric Inguinal Hernia Repair Conundrum. And we discuss the occult bilaterality of patent process of vaginalis in our paper. So we all know that pediatric hernias necessitate a prompt and effective surgical intervention, and the long-standing debate, particularly for a unilateral inguinal hernia, is what is the optimal surgical technique? Is it open repair, as traditionally taught, or is it minimal invasive surgery? Because most in today's time agree that bilateral inguinal hernia is almost a definitive indication for a laparoscopic hernia repair. But this persistence of this long-standing debate is almost a testament to the broader quest to identify what is the effective, safe repair for a unilateral inguinal hernia, and which is the repair giving good long-term outcomes. So the factors at play usually are age, comorbidities, surgeon experience, and parental preferences. So the proponents of open repair have always had the argument that the track record of excellent results are there. It is unnecessary to enter the abdominal domain, and the open repair is fairly easy with a very short learning curve. And also, they believe that the rarity of the occurrence of contralateral metacarpal hernia persuades them to do the open repair. On the other hand, proponents of laparoscopic repair quote minimum scarring with miniature incisions, improved visualization, particularly when the rings are directly in front of us, in front of the camera, and particular advantage of seeing the opposite side, and potentially faster recovery times and minimal complications as the advantages. So the questions that broadly linger around are: what is the incidence of a contralateral patent process vaginalis in a case of unilateral inguinal hernia? And what is the risk of a contralateral metacarpal hernia in an unrepaired patent process vaginalis? Because we all know that all PPVs do not become hernias. So does a contralateral repair put that side at a risk of complication? And lastly, does a contralateral repair lead to an increased operative time? So we aim to determine the prevalence of contralateral patent process vaginalis in our patients and to evaluate the operative time, the recurrences, and the complications of lap hernia repair. We did a retrospective review at our
electronic
institution,
medical records.
and all patients from 2016 to 2023 were included, and all these children were operated at our department in AIIMS. So we had a total of 255 children who underwent a laparoscopic inguinal hernia repair, of which 75% were boys, and the mean age of children was 45 months, which is roughly around 3.5 years. And majority of these unilateral hernias were on the right side. We found that the contralateral patent process vaginalis was seen in 48 of the 245 children, which was about 20%. And the operative time to repair a unilateral hernia was around a mean of 55 minutes. And with a presence of a contralateral patent process vaginalis, it was 68 minutes. So overall, our mean time for laparoscopic inguinal hernia repair was 58 minutes. We had no conversions to open, and our mean hospital stay was 2.2 days. This included the pre-operative stay, and the post-operative hospital stay. So our follow-up was 48 months, that are around 2 years, and we encountered certain complications as well, which included VAS injury, a vessel injury, 4 children had hydrocele, and we had 7 recurrences. Notably, these 7 recurrences, none of them were seen in the side where contralateral patent process vaginalis was repaired. So coming to the discussion, the advocates of laparoscopic inguinal hernia repair quote better visualization, the improved familiarity with laparoscopy over time, the avoidance of dissection of the abdominal wall, and possibly avoiding secondary cryptorchidism as the main advantages of lap. When we talk about surgical repair for inguinal hernia, we often quote the surgeon's point, that is open versus lap. But when we look at the parental perspective, which was studied by Holcomb et al., it was seen that more than 90% of parents, when given information about the possibility of a contralateral patent processus vaginalis, chose to have the inspection of that site done and prefer laparoscopy as this preferred modality. Because we all know today, parents in today's view, today's time, view healthcare as uh, a a similar endeavor compared to shopping or banking. And they see convenience as the major factor in making their decisions. And not only that, the second factor was concern for their child to be subjected to a second anesthesia, if at all there's a contralateral metaconus hernia. So when we look at the prevalence of contralateral patent process vaginalis as per data, the first paper was published around 1959 itself by Gilbert et al., where in their study, they had around 60% of patients that were explored having a patent process vaginalis. But when we look at later recent literature done by by including prospective patients by Valusik and Shalaby et al., we see the prevalence was around 20%. Our study also we saw prevalence of 20%. So roughly in literature it is from 20 to 60. We can take it around 40% now. So is a contralateral patent process vaginalis always a contralateral hernia? That's not the case. So we see that literature from 2013 showed that around 7% of patients had contralateral hernia when compared to 30% having a patent process vaginalis. From there, it is understood that not all patent process vaginalis become hernias. As far as the latest meta-analysis on as of 2020, it was determined that 1 in every 7 children would develop a contralateral hernia. So when we come to the operative time and the recurrence rates, when reviewing the literature, we found that our recurrence rates were similar to the existing literature. But when we see our operative time, one can observe that our operative time was fairly high. This is because at our institution, the residents usually take the lead of performing inguinal hernia repairs, and our consultants have been kind enough to supervise and allow us to operate inguinal hernias, because that is how laparoscopy in pediatric surgery would progress, and that is how laparoscopy has been taught to us as residents in our institution. So the intracorporeal suturing and the handling of instruments and the orientation, all of that are taught by our consultants there. So that is why our operative times are fairly high when compared to the literature. And more importantly, when we see the extra time to repair the contralateral patent process, we did not take much time when compared to the existing literature. So to conclude, approximately 1/5 of patients, that is 20% of patients with a unilateral hernia, have contralateral patent process vaginalis. And this can very easily be repaired in the same setting by laparoscopy without any increase in morbidity. And this provides the patient a chance of reduction of his risk for occurrence of contralateral hernia. So one must consider lap hernia repair as the default option for children with inguinal hernia. Thank you. These are my references.
Okay, Siva, thanks for the nice presentation and the wonderful paper.
Thank you.
I have a few questions. Do you, in your department, do the children with inguinal hernia have a pre-operative ultrasound scan done?
No, sir, it's not a routine.
Not a
don't.
routine.
Mm.
Okay. Otherwise, the ultrasound scans sometimes do pick up contralateral patent processes vaginalis.
But yes, sir, I agree. But we do see that radiology is subjective. I mean, the presence or absence of a patent ring is always subjective, and the ultrasounds usually don't even that we see that with undescended testers as well.
Have
So
you explored that aspect from the academic point of view?
no, sir, not really, because there's already abundant literature currently which says that hernia in children is a clinical diagnosis. So we didn't choose to go ahead with an ultrasound or even probably consider studying it.
And how many hernias in your department are operated open and how many are done lap?
Sir, by default, it's almost every hernia is operated laparoscopically, unless and until there's a specific request from the parent side or the consultant deems necessary. So mostly it is 95 to 96%, all of them are operated laparoscopically.
And what is the technique that you follow?
Laparoscopically, sir, again, it is based on the consultant's preference. We either choose to directly take a purse string suture around the internal ring, or
Do
divide the ring
you
and
just take the peritoneum or do you involve the underlying muscles also?
peritoneum only, sir. And
So
then, or the second technique is by dividing the peritoneum and then closing the ring formally.
okay. So
Again,
these two
bypass.
techniques are the ones that you follow.
Yes, sir.
Okay. And you followed up the children for 2 years.
Been 2 years, sir. So our patients are on follow from 2016. So none of them had many problems. The recurrences also that we saw, sir, were mostly from the earlier part of the series. That is in the beginning times when residents have been doing hernia repairs, and all of those recurrences also occurred from this on the symptomatic side itself. That probably could be due to edema at the site and probably a loose purse string, or one patient had transverse myelitis, so it could be a weak abdominal wall. All those
You
factors.
said that the contralateral processes vaginalis that you closed, none of them had recurrence.
None of them had.
Yeah. So were those children destined not to have a hernia at all on the opposite side? Was
Sir,
the aspect studied?
that is based on the existing literature, sir, because the risk is definitely there. At least a lifetime risk is there compared to normal population, and literature currently says 1 in 7 will develop. So instead of subjecting a child to a second anesthesia and future risk of second hernia, and giving the parents that anxiety that the child might develop a hernia in future, when we see it, better close it, because it doesn't take much time, doesn't cause any complications. So that's the philosophy we practice.
I mean, I had my paper published in Journal of Minimal Access Surgery just last month, where we studied about 650, 1,300 children with inguinal hernias. In half of the children, we didn't close the contralateral patent processes, and we found that only 10% of children in whom we do not close the contralateral PPV developed a clinical hernia, and this was in 5 years of follow-up. So, I mean, I don't know, but our results are quite different than what you suggest. Rakesh, any questions?
Yeah, two questions. As you are not going for ultrasound pre-operatively, so how do you take a consent? Are you telling that on in between the operation you will come and explain the opposite side is open, or you just take a consent that if there is a the contralateral side is PP is patent, we are going to operate that.
We're doing
So
the
what's
latter,
your
sir. We are
uh-huh.
actually explaining in this before itself that there is always a possibility that 20% chance that the opposite side can be open. And then if we find it open, we'll close it. That's what we tell them, and we take them for surgery.
Okay. And one more thing that I am also not doing a hernia laparoscopically. Basically, we operate only on a symptomatic side, open one. And I don't agree that this laparoscopy is, I mean, giving you the advantage like a fast recovery and this and that, because you are violating peritoneal cavity, general anesthesia. That can be done extra peritoneal and regional. But apart from that, I'm worried about that. You told the lifetime risk of happening hernia on opposite side is almost 7%. Right? You said it is once you operate on a one side, symptomatic side, there is a possibility of
One in
7% risk of
with the PPV. Yes, sir.
right. Okay. So the same thing, lifetime risk of appendicitis. Are you going through all the bowel when you are doing laparoscopic hernia to watch for the Mackles and this and that? Because there is always a lifetime risk of some infection later on in life. So can we go ahead with the bilateral hernia with appendectomy and searching for Mackles and this? I mean, what's your thought about this?
For hernia, we don't look at appendix and Meckel again, sir. So that
There
is
is
it.
a lifetime risk, If you don't
That is
remove
there.
appendix, there is a lifetime risk of another anesthesia, another laparoscopy, and definitely if it ruptures, it is even life-threatening in compared to hernia.
I agree, sir, but that does not enter. I mean, we should not go ahead. It depends on the percentage of risk as well. But when we're talking about hernia per se, we are already operating for one
We
side.
are, we are, we are talking about asymptomatic pathology. We are considering that hernia could happens. The same thing appendicitis
Because
can
we are
happen.
seeing a PPV, sir. It's not like that ring is closed and
No, but
we
you are
don't know.
already inside the abdominal cavity.
Hmm.
Everything will be visible up front.
So when we are finding an open ring, why not close it? That's the sort of discussion
When
we
we are
can have.
finding appendix, why not to remove it? It's there only.
That's not an open PPV and a presence of a normal appendix.
That's okay.
Yeah.
I am not into that just because
Yeah.
I'm not doing that laparoscopic hernia, so I don't mind. But just these are some query I was having. But one more thing that you showed the recurrence is in a seven patient, that is 2.7% on the symptomatic side, right?
On the
So
symptomatic
your
side.
protocol is like some surgeons divide the sac, others are not dividing sac.
Yes.
So I
Yes, sir.
mean, which set of people you find this recurrence?
There was a paper published from our institute itself, sir, 3 years ago on this same topic. To cut or not to cut was its title. So we saw that the recurrences were more common in the children that had their ring cut and then repaired. So probably could be inadequate closure or many other factors. One child had transverse myelitis, then we don't know the exact cause again.
I mean, it could be other way around. I don't know that
It could
even
be other way around, I agree, sir.
yeah,
But
because
yeah,
you're
that's
already
how our data was
creating a
out.
raw area around that once you cut
Mm.
the peritoneal cavity, and
Mm-hmm.
yeah. So for that recurrence, two patient was having a spinal dysraphism.
Yes.
I mean, do you think these patients are? They are actually candidate for open surgeries when you are considering spinal dysraphism, some weakness in the muscle, and
Could be, sir, but again,
that the first protocol is just go in and decide. Okay.
yes.
How were the recurrences tackled? Were they done open or laparoscopic?
So those were tackled by open
They were
because
tackled by open surgery.
open. All recurrences will be done by open.
So you mentioned it is like it based on a surgeon's preference again, and most of them are done laparoscopically. That is what your paper says.
The series that I mean the patients that had recurrence on with laparoscopy were operated, and again it was a surgeon's preference, sir. But in the end, by the end of series, by the time at least I was there, it was open.
Okay.
Okay, thank you, everybody. I don't think there are any further questions on the chat box which have gone unanswered. Dr. Robert from Bangalore says that, in fact, it would have been easier to operate recurrences by laparoscopy. What is your take on that?
It should be. It should be. I agree.
Okay,
Rasik sir can comment.
Manoj or Rasik sir?
Rasik sir, can we conclude or there are some
Yeah,
specific
we can conclude. I think
Rasik sir, any expert comments from your side regarding this paper?
I mean, I am advocate of excision of the SEC technique with that zero recurrence, means almost zero recurrence. I will put that way. Of course, you have to be more careful than just the closure because you have to dissect from vas and vessels. I think it all matters the experience. Probably all these recurrences of Jodhpur are because of the residents operating and they are learning. So, taking judgment from that is probably the wrong. I think if experienced people are doing it, the recurrence rate with SEC excision should be almost zero. I won't say zero, but almost zero. And other techniques, just closer theoretically has higher chances of recurrence. And then, like what you are saying, many other reasons may be there, like spinal dysraphism and other things, extrafibrillator spinal dysraphism in them, the chances of recurrence are higher.
Right.
So, I mean, I just can't digest that if you excise the SEC or cut it and the recurrence rate is higher, it means it's a problem with who is doing it. That is very clear to me. But anyway, I think everyone has their experience and they derive the how to do the procedure in, but only thing I will tell all the IAPS members that all these papers are giving you some idea, but we cannot take it as a gospel truth.
Yes.
We have to read in between the lines. We have to do whatever our judgment, and you have to think whether whatever is published, you think is it justified, right, wrong. You have your own experience, and then you take decision what you think is appropriate. And when you operate, and when you have your own experience, your judgment, that is the best. This is as a surgeon, I am saying, not as an editor in chief, but that is what I would say. if there are any comments from Amar and Rakesh before we close.
No, so that's very true. We always, as surgeons, we always evolve, and I mean, our results gradually improve. I mean, the same technique, if we do now and if we do after 5 years, the results are going to be different. So it's we all evolve as surgeons with age and with experience.
And two different papers in the similar month. That one is telling that you close that, another paper is telling don't close. So I think, yeah, it's a personal experience. But thank you, Rasik sir, for inviting us, and we really enjoyed and this will be remembered, and thank you very much for that.
Yeah, and I request Amar, Rakesh, if Vikesh and Dr. Sumitra Bishwas is around, to remain on board after Manoj does Thanksgiving. At least 5 of us will have to decide which paper will go for the final round.
Okay.
The best paper of this particular March issue and today's winner paper. Yeah, please, Manoj, go ahead.
Yes, sir. Before
Shiva Kamesh, sir.
Yes, I'm here.
Can you make one of us host?
Oh, yes. Sorry.
And you can leave the
yes.
chat.
So thank you all for joining today's General Club session. On behalf of editorial board, we express gratitude to our both the moderators, Dr. Rakesh Joshi sir and Dr. Amar Shah, for sparing your valuable time and raising really thought-provoking questions and very energetic discussions today for all these 3 manuscripts. We also thank all the 3 presenters, Dr. Saundarya, Dr. Shiva Kamesh, and Dr. Veerbhadra, for taking us deep insights of your published manuscript. Thank you very much. We also thank IAP, our Honorable IAPS President and our Secretary General of IAPS, Dr. Vikesh, and Dr. Sumitra Bishwas sir, for all their supports and their online logistic supports also. And a big thanks to all the participants. In fact, today, all the time they are above 70 plus participants have joined and have raised very thoughtful queries in the chat box, which led to very good discussions today. So please keep it up, and good night, and thank you till we meet for our next Abhigyan. Thank you very much.
Thank you, everybody.